But welcome everyone to, I think, our fourth REACH session. We have Dr. Dalgo here today, and he's going to be talking about ethical considerations in pediatric palliative and hospice care. So just a few little housekeeping things like we talk about before each meeting. Project Echo and REACH are going to be collecting registration, participation, chat comments. They use these for reports, maps, communication, surveys, quality assurance, evaluation, and just to inform new initiatives. We will be recording the session for educational purposes and making this available hopefully in about a week to you all on our website. Your data is kept confidential, so by participating, you're consenting to being recorded. And if you have any questions about that or concerns, feel free to reach out at our email. These sessions are accredited for CEUs through LMH PCO. Each session is 1.5 units. We do take attendance at each session and we monitor engagement. And you should be receiving an email following each session. So following this session, you should receive an email from LMH PCO that will invite you to complete a post-session survey. So do make sure you do that. You need to do that in order to gain the CEU credits. We did have some issues, I believe, with getting those, receiving those emails. So if you do want CEUs and you're not receiving those emails, do reach out to our email, and I'm happy to troubleshoot and make sure that you guys are getting your CEUs. So as far as Zoom etiquette goes, just make sure if you could and have the bandwidth to put your screen on just to promote engagement and a sense of community. While you're not speaking, stay muted as much as possible, and then do come off mute if you have a comment, a question. We do want to encourage that engagement. So please feel welcome to come off mute and ask questions or make comments. Again, reach out to us if there's any issues with your just hear. If you don't hear us at any point, you can either chat or email us, and we will troubleshoot. So just some ground rules. This is a safe space. Everyone's thoughts, questions, and concerns are valued and are valuable. We, want to have this as an opportunity to take space and make space for anything that you did want to share. And what's said here stays here, like the Vegas rules. So just to protect the privacy of all participants, we do ask that what's discussed here stays confidential. And when sharing real life examples from your work, which we hope that you do, make sure that you are just sharing de-identified information. Okie dokie. And then for the agenda today, we're going to start with welcome and introductions, and then we're going to review objectives for the session today. We have a didactic presentation that Dr. Dalgo is going to give that's today going to be kind of intertwined and woven in with the case discussion. So that's kind of going to be a simultaneous thing. And then we are intentionally wrapping up prior to the mindfulness activity so that those who don't find it helpful will not have to stay, and you can still receive all of the education related content. But yeah, we'll be wrapping up with a little mindfulness activity if you do want to stay around for that. Okay, so let me try to share my screen. Let's see. Sorry, y'all. I think it should be all good now. Okay. Ooh. Can you all see that?
I can see it.
Okay. All righty. Oh, I did forget to mention, if everybody could rename yourselves in your chat box. If you click the top three, the box at the top right corner, there's three little dots. Click that, and if you could rename yourself with your name and your hospice organization, that would be helpful for me as I track attendance. Okay. But yeah, if we wanted to go around, Stevia, did you want to call out names for intros, or did you want me to do that?
Yep, I can do the intros. Just looking at the screen, for me, it's blurry. Is it blurry for anyone else? Yeah.
Yeah, it's a little blurry for me also.
Okay. Let me get out of this. Sorry, y'all.
So while she's working on that, everyone though, just going to reintroduce myself. I am Stevia. I'm the nurse practitioner on the Pelican crew, the palliative care team here at Children's of New Orleans. And I am the co-leader of the REACH initiative with Dr. Autry, who will be back next month from maternity leave. So I'll get to see her face again. And so let's start with getting everyone's name, organization, and role into the chat. And then I see a lot of you already have your practice location behind your name. So get the chat going. And Maggie, if you're not able to share your screen right now, that's okay. I can just introduce Austin, and then he can take over the screen sharing from there if that works.
Yeah, if that were, it's still for some reason loading, and I don't know why it's blurry. I apologize.
That's okay. That's all right. No worries.
Dr. Dalgo, does that work with you to share?
Yes, that's fine.
Okay, perfect.
Do you want me to share it now, Stevia?
Yes, if you want to, that's great. And I'll just start on the objectives slide.
Can y'all see that?
Yes.
Yes, it's better now.
Let's see, is that no objectives? There we go.
All right. So our objectives for today's talk are to review the unique aspects of end-of-life decision-making in pediatrics, discuss common challenging scenarios in pediatric and hospice care, and acknowledge that this work can lead to moral distress and review strategies for mitigating this distress. So today we are very lucky to have Dr. Austin Dalgo join us from Le Bonheur in Memphis, where he serves as a pediatric palliative care physician and director for the Center of Bioethics and Health Equity. Dr. Dalgo, take it away.
All right. Thanks, Stevia. And I am so much better at interactive things. And so if you are eating, you don't have to interact if you need to focus on your food and fill your belly. But I have like just raging ADHD. And so I know that if I sit around and listen to somebody talk, I just tend to start playing Wordle or other games on my phone. And so I'd be more than happy to have more conversation here than teaching. So what we're going to talk about today are I think actually technically four things: shared decision making, the rule of double effect, truth telling, and then moral distress. And so we'll talk about each of these. And I don't know, maybe y'all have a lot of expertise. I bet you do. And even if these words aren't familiar, I know truth telling is familiar to everybody, but I think you'll recognize a lot of these concepts. So let's talk about shared decision making. Shared decision making is kind of the gold standard in how we make medical decisions. Back in the day, the doctors would kind of make the decisions for everybody, decide what information they shared and didn't share, and then kind of in this very paternalistic way would say, this, I think this is what the best thing to do is. The 1970s came around and there were lots of movements, civil rights, women's rights, people really demanding that they be treated as equals in a good way. And so there was really a movement for patient rights as well. And in 1990, the Healthcare Decisions Act was passed that basically said, patients have the right to make their own decisions about what treatments that they want. Back in the day, fascinatingly, doctors were the ones who were arguing not to take patients off of ventilators. Now it's the other way around. The patients seem to want more medical treatment than the doctors are comfortable providing sometimes. And so the shoe's on the other foot. But back in the 70s and 80s and even into the 90s, there was this concept that really, taking somebody off a ventilator, even at the end of life, was akin to killing the patient or being a participant in, the murder of a patient. And so this went all the way up to state Supreme Courts and even the U.S. Supreme Court to think through these issues. And so what we've decided and landed on, which I think is a good thing, is that doctors and patients and medical teams, I'm sorry, don't let me be doctor-centric, medical providers and patients and families should be making these decisions together, right? And nobody's an expert on all the information. Families have their social context and their values and medical information, and doctors have medical information and some knowledge of the social context and the family values. And so we should bring those two expertise together and reach an agreement and reach a decision. And that's the ideal. That's what we're shooting for all the time. And so it turns out that this takes a lot of time to make shared decisions. We in palliative care understand this, and that's why we have job security, because a lot of other doctors and medical providers don't take the time to do this, right? And so we're sitting around having these conversations, understanding families' values, and saying, it seems from our previous conversations that things that are important to you are this. So it seems like maybe we should move forward on this, down this road. You tell me what you think. Does that make sense to you or not? And I think that that's an approach that I often take with families after I understand and learn their values. And then the other thing to point out in pediatrics, we're not sitting there with a 5-year-old and saying, do you want your chemotherapy today? Shared medical decision-making is not the gold standard if you don't have capacity to make your own medical decisions. And so this comes down to the decision makers, which are typically the parents or the guardians. And they don't technically give consent, because consent is supposed to be something that somebody does for themselves. They give informed permission, but this is just ethical jargon that doesn't really make that much of a difference. This is sort of the spectrum of decision making. Are we going to lean more towards a team guided decision or more towards a parent guided decision? In general, these two things should work together. But let's say, for example, a child has meningitis, and we obviously want to treat the meningitis. We're not going to really ask the parents, should we treat your child for meningitis or not? Because we're going to do it. Because there's grave consequences if we don't treat the meningitis. And so that tends to be more of a team-guided decision than a parent-guided decision. 99.9% of parents want their child treated for meningitis, so this really isn't much of a dilemma. But then when you start to think about things like tracheostomy near the end of life, or a G tube in an adult patient with dementia, those become sort of more of a balancing act that we're thinking through. And so you tend toward the team guided when you have good evidence and that there's really a high benefit to burden ratio. And then you tend towards the parent guided decision when there's, kind of like we don't know what the best decision is. There might be more than one option, and they all kind of seem to be equal benefit and burden ratio. So anyway, that's kind of how we think about it with shared decision making. What I want y'all to do is think about examples as I talk of when shared decision making, when you've taken part in this or when you've seen it not go well. And then we'll talk about some examples in a couple slides. Throw in the adolescent into the situation. Anytime you throw in a teenager, you're going to complicate the situation, right? It doesn't matter if it's, a medical decision or if it's who's going to clean the house today. Teenagers tend to complicate life, and which is a good thing. I love teenagers. So I think I still act like one most of the time. So when you're thinking through a decision, you have to really ask yourself, what role should a teenager play in this very important decision? And one thing that's really important about consent for a teenager is what is the complexity of the decision that's being made. Let's take, for example, teenagers in the hospital and they're having a lot of pain, and we have Tylenol and morphine on the med list, and we're like, are you in moderate or severe pain? And they say, I'm in severe pain. Well, would you like to try the Tylenol first and then the morphine, or do you just want to go straight to the morphine? That's a fairly simple decision. It's not going to have lifelong consequences, and so we will tend to let simple decisions, you don't need complex decision making, and so a teen can make that decision fairly easily. But if it's more like, you have a lymphoma and your chances with survival are 60%, do you want to go down the road of chemotherapy, given all of these, different complications that may occur? And that might still be a teen guided decision, but it also might be a place where we're kind of leaning a little bit more into the parents' thinking in that process. So with teenagers, with the triad, it gets a little bit more complicated. Before I get into this case, I want to hear from the audience. I'm going to stop sharing for a second and see if anybody has any examples of shared medical decision-making or really bad decision-making processes that you've experienced in your career. Man, this is a good palliative care group. We're all just quiet. Anybody? If not, that's fine. I'll tell you my story. All right. Oh man, it made me start at the beginning. Here we go. Angela. Start there and hit that. Are y'all seeing Angela?
Yes.
Okay, cool. So Angela came into St. Jude, and she had been treated here for a while with metastatic for rhabdomyosarcoma. She had metastatic cancer, and despite going through several chemo protocols and radiation, her cancer continued to spread. And the options were presented to Angela. Really, we could do some oral chemotherapy to try to buy you a little bit more time and control your symptoms. There's intensive chemotherapy that would likely be highly toxic, but may give you more time if you respond well, or sort of not doing cancer-directed therapy and focusing on comfort. And so the parents, the team felt like oral chemotherapy or hospice care was probably most appropriate. The parents felt like that was reasonable and really wanted to kind of lean towards the oral chemo. And but Angela really felt strongly that she wanted to pursue more intensive chemotherapy and give it a chance to maybe kind of, lean more towards cure or more life prolongation. And so there was a lot of discussion with the team, the parents, and Angela about what to do. And they, as they talked, they recognized that Angela was really able to understand a lot of her disease, that she was able to reason through all of the alternative options in the main treatment course, and that she was able to express an opinion and say, I understand the risks with moving forward with intensive chemotherapy, but I really want to get to my senior year and graduate. And she wanted to have that ability to do that and wanted to take a chance. And so through a lot of conversations, she decided to go ahead and move forward with intensive chemotherapy. And so again, this is sort of just a representation of the team wanting oral chemo, Angela wanting intensive chemo, and the parents wanting to go home. And so as they thought through this, they thought, all right, what are the dynamics of this relationship? Who is the legal decision maker in this process? What if Angela and her parents didn't have a great relationship and her parents said, no, we will not accept chemotherapy, and Angela said, yes, I want it? Who would we go with in the end? Any thoughts on that? What would y'all do?
She's 17. She's got a clear vision of what she would like, and she needs to be heard.
Yeah. Thanks, Judy. Any other thoughts?
That's a really
What was her
hard.
age?
I'll pick
What
Courtney.
was her age again?
17.
I think that her wishes should be heard and acknowledged. I think she's old enough to know what she would want to do.
Mm-hmm. Yeah, so even though she's not legally an adult, she's pretty darn close, and it seems like she's able to express herself well, understand things pretty well. She's been through this chemotherapy course before, so she has some knowledge of it, and all of those contextual factors lead us to kind of want Angela to kind of guide and lead this decision-making process. And I think that that's kind of how the team felt in the situation too. So she was a fairly mature 17-year-old who really did seem to understand what the risks and benefits were of pursuing this course of action. And they thought that they should honor this. And what's interesting that we talk about, we think about the term autonomy a lot in shared medical decision making. Autonomy just means the ability to make decisions for yourself. In sort of Western bioethics, we tend towards that bias, that the individual gets to make their own decision. But it turns out that doesn't really work in real life. A lot of people don't want to just make decisions by themselves. They want to have their parents involved in their decision making. They want to have their loved ones involved. And even if you're an adult who has the ability to make your own decisions, I'm still going to ask my wife what she thinks. I'm still going to ask other people who love me if they think that this is the right decision. And so I think the term relational autonomy is something that we have started using a lot more in bioethics. And that's a way to think about decision making, not just in a vacuum of the individual making the one decision, but the context of the relationship. And so a teenager might say, I want this thing to be done, and we go with that. But then other times a teenager might be like, I'd like my mom or dad to make this decision for me or to help me with this decision. And that's a totally legitimate way of making shared medical decisions, not just always looking to this one person, but maybe different contexts and different decisions call for different types of autonomy, types of decision making. And so I think that this is a really important thing that we think about in end of life care is to think, each decision might be made in different ways with different people, and we should allow for that. And then the other thing to think about is developing autonomy for teenagers. And so we should practice as providers, not just saying, oh, you're 18, now we flip the switch and you get to make all the decisions. We should be starting from 8, 9, 10 years old as pediatric providers, letting kids have the opportunity to make decisions, even if they're small ones, right arm or left arm for your immunization, right? You can make that decision at 5. And then, when you get a little bit older, maybe you think about, should we get your blood work today or the next visit we come into the doctor, or do you want the oral amoxicillin or the penicillin shot for your strep throat? So those are things that kids can start doing, and we really should be working toward that graduated autonomy. But so often in these end of life situations, we've never let the kid make decisions, and then now we ask them to make this huge life decision, and they're really thrown off. And so I think it's something that we really should think about as a group. Like, how do we really encourage our young children to start making decisions for themselves? All right, any thoughts or questions or comments? This is kind of a busy slide that I'm not going to necessarily get all the way into, but I think that that this sets out a lot of what I've said before, but puts it in kind of a more discrete fashion. When you're thinking about decision making, the first thing you do is you never ask step 0 is never ask a question that you don't want to know the answer to. We shouldn't ask a child for permission to do something and then they say no thanks, and then we do it anyway. That's something that I think we see a lot of times in pediatrics is and I do it to my own kids sometimes. It's like, hey buddy, are you ready to take a bath now? And my 4-year-old's like, no, I'm not ready to take a bath. I'm ready to eat some dessert, and it's like, oh crap, I shouldn't have asked it that way or said it that way. I should have said, hey man, it's time to take a bath. Let's go do that. And so just think about your language in that way so that you're not asking questions that you don't want to hear the answer to. And then I think when it is time to make a decision, we should only present medically reasonable options. So one example in my hospital currently is a patient that experienced severe HIE who's about 2 months old now. And one of the attending physicians said, she's having trouble managing her secretions. And one of the attending physicians offered a mandibular distraction, which is basically breaking the mandible and moving it out because she has such a small jaw. And we all were like, oh no, like this should not have been an option because this child is likely not going to survive past a year. And breaking the jaw and continually moving that out, it seems like a really highly morbid thing to do to a patient who may not live for a very long time. And so one is only offer medically reasonable options, and then don't be afraid to make recommendations. Just because like we've thought about patients' rights to make their own decision doesn't mean that we as medical professionals need to be silent about what we think makes sense. But we have to do it in a way that's sensitive to the family. We don't want to say, this is what I think you should do. Instead, we should say, based on the conversations we've had and the values you've expressed to me, this seems like this might be a good choice for you and your family. That's a way to do it in a patient-centered way rather than in a way that's like me imposing my values on somebody else, because that's not something that we're really called to do. And then when these kinds of decisions become difficult, we've already involved palliative care, we've already done all the conversations, and then we bring ethics involved and we say, you know, what are the reasonable options here? Is this treatment potentially harmful to the patient? Like, for example, you know, you have a progressive cancer and the patient's not waking up, but the parents are asking for a tracheostomy and a ventilator. Maybe we need to really talk about whether or not that's beneficial to the patient or not. And then if there's disagreement, how do we manage that disagreement? And ethics consultation can really help with that. I know a lot of folks on the call are doing outpatient hospice. Have people been involved in ethics consultations in the past, and how has that gone for you?
We had one who had for chronic respiratory failure, and the parents were dead against having a trach, but she went into cardiac arrest and went to the hospital, winded up getting a trach, and winded up being very good for her. She had lost like 20 pounds just from effort to breathe.
Mhm.
And once she got the trach, it was a year ago, and I just discharged her as a chronically ill patient instead of a terminally ill patient, because now she's got a stable airway and has not had an infection or a hospitalization in the last year.
Yeah. So that was an instance where the family was really against a particular intervention, but the hospital or the medical providers really felt like that intervention would be helpful to the patient. And so that was kind of tell me if I'm saying this correctly. That was a decision that that maybe the medical providers and the family didn't agree on initially, but now we see that that's really provided a lot of benefit for the patient. Am I summarizing that correctly?
Yes, plus also the family, the mom and dad are going through a nasty divorce, and dad didn't want it, but mom did.
Gotcha.
So they called ethics in and talked with both of them, and then they came to the decision to put the trach in.
Gotcha. So this was a decision that the parents agreed to prior to the placement of the trach. It wasn't something that was done without their consent.
No, it wasn't done with their consent.
Yeah. And that brings up a really important point, which is many times there are social and relational aspects to decision making. So when there is disagreement, you might, as an ethicist, you might sit down and say, hey, this is a confidential conversation. I'm just here to listen and try to help as much as I can. And you might get some more detail about, relational problems or divorces or whatever else that might be happening in the background that really could be influencing the medical decision making that you kind of didn't know about before.
Right.
And Katie said in the chat that she's had success reminding patients that we'll always be open and honest with them, and that saying that we're going to be honest about decisions that we think are beneficial has really helped with her adolescent patients. And so I think that that's really important, is just the expectation of honesty up front. Okay. So now we'll move on from the shared decision making to the rule of double effect. Has anybody heard of this before? I see a couple nods. Anybody want to take a stab at defining it, just for funsies? I'll do it for you. So the idea is that we want to do that an action is only bad is if you intend the bad effect. In other words, and we'll get to morphine as an example. In other words, if I intend to bring you comfort through the treatment that I give you, and through that intention to bring comfort, a side effect occurs, such as respiratory depression, and that leads to death. If my intent is to bring you comfort through this intervention, then I'm doing a good act. If my intent is to give you a huge dose of morphine or Dilaudid that's going to stop you breathing and lead to your death, then I'm not doing a good act. I'm doing a bad act, assuming you don't believe physician aid in dying is morally acceptable, which we can talk about that on a different talk. But I think that the idea is, what is your intent behind the action? Is it to bring about the good of comfort, or is it to hasten somebody's death? And so is the action good in itself? So I can't intend good through a bad action. I can't say, well, I intend to relieve your suffering through this, violent means of death, right? I can't do that. I should intend good. I should, the good effect shouldn't be produced by the bad effect. In other words, I can't say, I'm going to hasten your death, therefore bring you comfort. I have to say, I'm going to give you this medication to relieve your pain, not end your life. And then it has to be all of it, the other things. So an example is administering opioids. So for example, morphine can cause respiratory depression and relief from air hunger. That's a good effect. The bad effect is I can hasten your death if I give you too much morphine. So the goal here is to relieve suffering. A good example of this is one that happened here at Le Bonheur. 3-month-old who was born early, who had severe hypoxic ischemic encephalopathy, never really seemed to be awake and interactive with the world, but had a G tube. And he went home to the he was admitted to the hospital with pneumonia. And so through discussions with the family, we arrived at the conclusion that the parents wanted to extubate Michael at the end of life and make sure he stayed as comfortable as possible. And the parents felt like this was really the right decision. We talked about tracheostomy with them, and they felt like, no, I don't really want him to be technology dependent. And we don't feel like that would be a good quality of life. So we moved towards extubation. As we extubated him, we provided a significant amount of comfort medications. He was intubated for quite a while in his life. So he was on long-acting opioids, short-acting. He was on oxygen, which most of us know that oxygen itself at the end of life does not relieve respiratory distress. However, airflow does seem to improve symptoms of dyspnea. So you don't actually need oxygen if you just have a fan across the face, or if you just want to have some flow, then that's enough. And then we were controlling his agitation with clonidine and benzos, and then secretions as well. And so that's so with Michael, we gave him a significant amount of medications. And the thing that the nurses always say to us when we order all these things is, I'm nervous that I'm going to be the one who gives the last dose. And I will then feel responsible for this patient's death because I gave the last dose of morphine or Ativan or whatever it might be. And so and that's a very understandable position to be in. Like, you don't want to feel like a person that led directly to somebody's death. And there's no obvious response to this, except for one is it is the patient's natural history of his disease that he's dying. It's not you hastening his death. Secondly, there's always a last dose of morphine, and maybe it's not even related to the morphine for the reason that the patient's dying, and it's just we're making sure that he's comfortable at the end of his life. And so, and then finally, just like the rule of double effect says, like our intent is to make him comfortable, not to hasten his death. And so, if we have that intention, then I think we're on good ethical grounds. The other thing is we don't actually need this rule of double effect with morphine. You know why? There's actually sorry, I thought it was on the slide. There's actually really good evidence that aggressive pain control and dyspnea control at the end of life does not hasten a patient's death. And so they looked at patients in the ICU that got sort of routine care, and they actually got less morphine and Ativan than patients who got aggressive symptom management with higher doses of morphine and Ativan. And the patients in the group that got the aggressive care actually lived slightly longer than the patients in the routine care. And so what I think we're doing is we're providing enough comfort that the patient is actually breathing better and breathing more comfortable. And we're actually prolonging their life slightly through these comfort medications. And so even though many people are worried about giving morphine and Ativan at the end of life, we actually have pretty good evidence that it does not hasten death at all in any way, shape, or form. So we can all take a big, deep breath and take a sigh of relief that we're not hastening anybody's death in our work. All right. That's the end of that section. Anybody want to give any testimonials or thoughts on the rule of double effect and experiences you've had with that? Oh, Christy, you have your hand raised.
Yeah, I think that we need to educate, especially with the parents, that we're intending, especially if it's the first dose, we're intending for comfort, but this is what could happen. Sorry, my patient's crying. That what could happen, and because sometimes the first dose can be the last dose.
Mm-hmm. Yeah. No, I think that's important that we have those conversations fully with people beforehand. And you know, you're giving us a nice foreshadowing into the truth-telling part of our talk. But I think that there's a lot of people who are worried about the words morphine and methadone because they've heard them in the setting of addiction, and they've heard them in the setting of hastening death. And we really do need to talk to people and say, you know, when we give these medications at the properly dosed level, then are the chances of this medication hastening death is very low. We actually see a pretty clear progression from a person who's in pain or dyspneic to being awake and alert and not in pain, to then getting kind of sleepy, to then getting very somnolent, to then being obtunded, to then stopping breathing. And so you see this clear stair step from being in pain to being awake all the way to not breathing with escalating doses of medications. And so if dosed properly, we're almost never going to hasten somebody's death. And if we're aggressively treating their symptoms, maybe that might happen, but evidence is to the contrary that we're actually doing that. And so, again, I think you're right. Education is super important. Dispelling myths is super important, and just helping people, you know, navigate what is probably uncomfortable for them, primarily because of the stigma of opioids. Anybody else?
Hey, it's Stacy at Children's in New Orleans. I find that people who have medical background probably especially nurses, if they're family members, when people, they start talking about morphine, they tend to be way more hesitant of that, maybe just because of our knowledge.
Mhm.
A little bit harder
Yeah.
to, like, you feel, to like convince them, really it's for comfort. They're like, oh, no, they know the real deal.
Yeah. Yeah, no, I've started in my practice really just like anticipating those questions. And so whenever people are oops, I'm sorry, I didn't mean to do that. Whenever I'm talking about comfort medications, I always say at the very beginning, like, so we would give medications like morphine and Ativan, and I know that those are medications that maybe you've heard of before, maybe not. And sometimes they get bad raps because, people think about, them stopping people's breathing or making them so comfortable that they're just asleep all the time. And I'll tell you that our goal in giving this medication is to make sure that your child is as comfortable as possible. Our intention is not to slow down their breathing or to make them all the way asleep, unless that's what you think we should do. And it's really just to keep them as comfortable as possible. And so, like, I do that even before they ask the question now, because I think I want to just dispel those myths even before they come up. But yeah, I appreciate that for sure, Stacy, and I think that's really true. Other thoughts? I had fried chicken for lunch today, so I'm like so sleepy right now. So finally, truth telling. I think this is really important too in teenage patients. This example is Isabel, 13-year-old with Willem's tumor, and she came to St. Jude for a phase 1 trial. Phase 1 clinical trial just means we're trying to figure out what the right dose to give is that doesn't cause toxicity. And so phase 1 trials, by definition, are not meant to cure patients. They're meant to find the right dose of medication. And so a lot of families come into St. Jude here looking for a phase 1 trial that's like basically a Hail Mary. And they are still hoping for cure, but really that's not what the intent of a phase 1 clinical trial is. And so the hospice team here, called the Quality of Life team, comes in, and the father basically says, I don't want anybody to mention the word palliative care or hospice to my child. This is, I don't want her to have to think about end of life situations. So this obviously causes some worries. One, does the patient understand that they're dying? And are we being totally honest with her about that? Does the patient understand? Do the parents understand? What if we slip up? Like, I was just talking about this with some of my students. We have a ethics consults in the adult world a couple times a year with patients who have HIV, and they say, please don't tell anybody in my family about my diagnosis of HIV. And, lo and behold, a person who doesn't typically take care of this patient walks in, and they let it slip that, we're treating HIV, and the patient feels totally betrayed by the medical team. And we haven't communicated with each other enough to make sure that that doesn't happen. So what if we talk about hospice and palliative care because, the person covering that day didn't realize that this was something that we needed to be aware of? So that's a concern. Can we really provide good care if we're not being honest with Isabel about what's going on? If she asks, why am I, getting this morphine all the time? How do we answer that question? And I think that that's a really important thing to think about. And the other thing is, what about the parent-child relationship? If you're at the end of life, the last thing that you want to worry about is my relationship with my parent totally honest? And if the child knows they're dying and the parent knows that the child is dying, but they're not talking about it, is that creating a distance in that relationship that's unnecessary? And I think that that's a really hard situation that many medical providers face in these types of situations. And, the truth is every family is a little bit different, and we can't necessarily impose what we think is right for that family unit onto them. I can say that there's pretty good evidence that families who talk to their kid about their diagnosis typically don't regret having those conversations. But families that don't talk to their child about their diagnosis and their prognosis, a significant proportion of those people do regret not having their conversations. So there's more regret by not having the conversation than there is by having the conversation. That doesn't mean that that's true for every family, but that is kind of the way that the literature is leading right now. So how do you align with the family who doesn't want to talk to their kid? We here at Le Bonheur, we had a kid with a teenager with a heart condition. He had already gotten a heart transplant, but his heart was failing and he wasn't a candidate for a second. And his parents said, only positive things come into this room. We don't want any negative news. He's already sad enough. Please don't mention anything about the fact that he's not going to get another heart. And so we had to sit down with the parents as the team became more and more distressed that he wasn't in on the conversation, and said, what are you worried about with talking to him? And can we help, navigate this situation in terms of your worries? Like if you're worried he's going to be more depressed, can we maybe bring in a counselor or bring in a child life specialist who can help with this? And then also being honest with the parents that if he asks us direct questions about am I going to get another heart, we can't lie to him. That's not in our sort of moral wheelhouse to tell lies. We can try to kind of give general answers, but we can't deceive him intentionally. And so anyway, those are some strategies that we thought through. What we ended up deciding in our case was that the parents just didn't want the team coming in every day saying negative things. And so they were okay with having prognostic discussions, but just only on sort of a titrated basis, which is totally understandable. All right. Any thoughts or questions on truth telling or telling the whole truth to children? What do y'all think about that?
I personally think that, as a medical professional, especially dealing with hospice, whether it's pediatrics or adult or teenagers, having some ability to be able to openly communicate about the reality of what's going on is so important, because that's unfortunately in our culture, that's just not something that is done a lot until we get to the very end. So then it makes the very end even harder to accept.
Yeah, that's a good point, Courtney. We tend to skirt around the issue until it's absolutely facing us head on. And that's just like what I was talking about with teenagers. We don't let them make decisions until they're 18 exactly, and then we pull the rug out from underneath the family. And so I think that these ways of what I like to, it's like cultivating a garden. You have to cultivate truth telling and prognostic awareness over time. It's not one conversation, but it's many conversations over time. And I think that we really need to focus on the process of that rather than just a one-time, honesty or not honest, but let's be honest over time. It's like the sex talk with your teenager, right? If you just have one talk about it, then they're rolling their eyes and they're like, I already know all this stuff, mom or dad. But if you sort of integrate what it means to be a sexual being throughout, developmentally appropriately throughout their lives, then all of a sudden those topics don't feel taboo to your family or to the kid. And so we need to have that same culture in end of life situations. Death is taboo to adults, but it turns out kids are more open to having these conversations because they don't understand our taboos. And so I think if we can cultivate those kinds of conversations, that's very important and actually fairly natural, I think, for the children. So we've talked, oh, go ahead, Stacey. I was going to say we've talked about sex and death. Now we just need politics. Stacey, you're up.
It's always interesting when they're in the hospital and they're 17 and their birthday occurs while they're in the hospital. So literally today, mom's making your decisions and, oh, happy birthday. Now today you are. And it's so wishy-washy.
Yeah. And I think that we have to be, it's just like being culturally sensitive with other cultures. Like we're not going to impose if there's a family where the moms tend to make the decision, sort of a matriarchal family, we're not going to then come around and say, all right, dad, start making a bunch of decisions now. We need this to be a shared decision. We let the mom sort of run the show a lot of times when that's the way their family is structured. And the same should be true with teenagers who turn 18. If the structure of decision-making has always been, that the parents are making the decision and the kid's kind of quiet in the bed, we should have been thinking about that ahead of time. But secondly, we shouldn't all of a sudden just disrupt that culture of that family just because it was a birthday. And so I think in the same way we think about cultural sensitivity, we should think about developmental sensitivity for teenagers as well. Any other thoughts? All right, let's talk about moral distress. Our jobs are hard and we deal with a lot of sad stuff. I see a therapist on a frequent basis, and it's important because if we're dealing with these difficult situations and not recognizing it, not talking about it, stuffing it down, then we're gonna end up like mowing our lawn and crying for some unknown reason, and we're just not able to access why we're emotional in that moment. And so I think what we have to do is to think about what are these to dwell on these difficult situations and to allow ourselves to process them internally, but also with friends and loved ones and trusted people. And so moral distress is defined as a situation where you know what the right thing to do is, but you don't have the resources to accomplish that. And this was actually started in the context of nursing, because oftentimes nurses are stuck in between the doctors who put the orders in and the families who make the decisions, right? And so, hey, nurse, go perform this activity that you haven't really been a part of making the decision on. And so that leads to moral distress. And so I think that it's important for us to recognize the signs of moral distress. That's fatigue, that's lack of compassion, that's feeling like your job doesn't have any meaning anymore. That's feeling like you just don't want to go to work that day. I mean, some of these we can have occasionally, but if you feel like that on a consistent basis, those are pretty good signs of moral distress. And burnout is sort of the end of the spectrum of moral distress. And once we reach burnout, it's really hard to get back. And so it's really important that we think about preventative ways to manage our moral distress so that we don't get to that point of burnout. So that's all I've got. What thoughts, questions do you have? Anybody have a particularly difficult ethical situation that they've dealt with that they want to talk about with the group?
I'm thinking there's just so many, right? And that it ends up being morally distressful for the team, for the nurses on the units, for the bedside, the physicians, the nurses, the families. There's so many.
Mm-hmm.
We touched on lots of.
Yeah, I've got a debrief in 53 minutes with the PICU, who had a really bad outcome with a patient who has asthma, and got put on ECMO and passed away within a couple hours after being put on ECMO, and it was a really unexpected death. And I think that there's grief involved. There's the idea of like the vicarious trauma, right? So we're not the ones who are experiencing the death of a child, it's the family, but because we're experiencing it frequently and we see and we're bearing witness to that, we are a part of that story as well, and we experience the trauma and the grief as well. And I think that in the old school days, people used to say it's not your grief to have, but I think we've all learned better now that we share in that grief, and that's actually more human and better for us to be a part of that grieving process rather than to say it's not ours to have. I think also that having a community where we can reach out and talk about these things is really important. For me, I'm more of an individual processor. And so sitting down with a pen and paper and just writing what my thoughts are and processing them is very helpful. I can kind of sit around and talk all day long, but not necessarily process it internally. And so that kind of that more kind of solitude helps me. What strategies do y'all have to deal with this difficult situations and molds?
In New Orleans, we just drink a lot.
Yeah.
I'm kidding.
That's true in Memphis too. Don't worry.
Inappropriate humor,
Mhm.
cynical denial. Denial
Yeah.
works really well.
Yeah. I was talking with my therapist one time, and I was asking him, "Am I like a terrible person for having, for saying these sort of like humorous but like darkly humorous things?" And he's like, no, like that's like a pop-off valve. It's like you sort of like it's a way to deal with grief in a way that lightens the situation. And like I always say in a palliative care consult, I never just stay in the hard and difficult situations. I always let families come up for air, is the way I describe it, and like let them like have something happy that they talk about or make some stupid joke in the midst of this, because then people feel like they can take a breath and not have to talk about the hard stuff all the time. And so I think we all need that too throughout the day. We need to take a breath and not just deal with the difficult stuff throughout the whole day. But if we're always avoiding it, then that's probably not a great plan either. And I've had to process that with my therapist as well. I'm definitely more of the avoider than I am the jump into it kind of person.
One of the things that I'd like to say is, you had brought up about letting them come up for air. And I think during really difficult situations to go ahead and lean in with them, but also to invite them to share a more joyful time. Mm-hmm. When they pull out their phone and they say, let me show you this picture. And they just celebrate those little victories. And I think it's very important for them, but it's also very important for us.
Yeah.
You see a different side of that little patient family.
That's so true. Actually, I think that should become a standardized part of every palliative care visit is, hey, you have any pictures on your phone that you can show me? Like that should be a part of what we do every time. And it's one of those moments where people realize, oh, you actually care about me and my family. You're not just trying to check boxes. You just want to see what our lives are like. And that's really nice. One of the concepts that I've really appreciated lately is what's called moral residue. And so that's sort of the idea of moral distress that happens, that then goes unaddressed and keeps happening over and over again. And so let's say we have the situation where a patient didn't get the adequate amount of pain medication and they died a painful death. And you see that that's a problem because, the medical team's afraid to prescribe the right amount because they're afraid they're going to hasten the patient's death. And then you see it again 3 months later, and it still is happening, and nobody's really listening to you. And you say, hey, this is a problem. And then, it just keeps happening like that. And that builds up and builds up over time. And even though each particular situation is distressing, but it's something you can get over time, it builds up to the point where you do feel burnout, and you do feel a sense of futility, and that nobody listens to me and things aren't changing. And I think that that's a really important part of a really important thing to recognize, number one, in ourselves, and then number two, to really start to figure out strategies to address that on an institutional or programmatic level. And in ethics, at least in the hospital setting, can be one of those ways that you can address it. I see this happening, and this pattern bothers me, and I think we need to address it as a whole hospital system or as a program, and going to your leadership and saying, we need to address this. If your leadership doesn't listen, that's when ethics comes in. And at least in our system, our hospice would fall under our whole system ethics committee. And so we could address it on an outpatient basis. And so if you're dealing with something like that, it's probably helpful to reach out to ethics and say, this is a pattern I see, and we need to address it. Sort of that empowerment idea. I probably gone over, Stevia.
You haven't, but I think that ending on empowerment is like the perfect way to wrap up this session after ethics can be kind of heavy and brings us back to some difficult cases. So thank you so much. This is excellent. I think learned a lot of great content here, and your expertise is amazing. So I think now we can head into our mindfulness activity for anyone who wants to stay on, and we can wrap up then.
All right. Thank you so much for having me, and great to see you, Maggie.
Thank you so much, Dr. Dalgo.
All right, bye.
I think we'll just start with kind of changing it up a little bit, and like we did before, kind of have everybody stand up. But I want to talk to y'all a little bit about this really super cool pose. And it's like, they call it the Superwoman pose, but I'm going to go with superhero pose. So if you have room to stand up and put your hands on your hips and take a couple deep breaths, they've done studies that show that if you stand like this for 2 minutes, they did studies after 2 minutes, increases your testosterone and decreases your cortisol level. So it can really decrease stress, gives people what they need for, like if you're going into an interview or a particularly difficult conversation, or like needing to shake off some of this ethics stuff, right? Blah, right? So take a couple deep breaths and then just have a seat. And we'll go into this. I'm going to kind of talk us through this really quick. Take a few deep breaths and just kind of check in and see where you feel right now. How are you feeling? We've been sitting for a while. And then if you're comfortable closing your eyes, close your eyes. I'm just going to talk you through. Take a couple deep breaths and imagine at the crown of your head, a ball of white light over your crown, about the size of a volleyball. And picture this light as pure, loving energy. In that ball of light is complete healing, compassion, love, and bliss. Notice the ball beginning to shrink a little bit, becoming the size of a softball, still glowing brightly, filled with all the good things. Again, making it a little bit smaller, more compressed, so it's the size of a golf ball, but soft and loving. And imagine that ball entering the crown of your head, and wherever it touches, bring all love and healing. Picture it gently swirling around your head, lighting up your head with calm and relaxation. Continue that feeling down your neck, washing away any discomfort or tension. Allow that little glowing ball to pick up any tension. Watch the ball as it moves over your right shoulder, down your arm, to your elbow and wrist, your hands and fingers. Moving all the way back up your arm, leaving that right arm relaxed and at peace. Picture that ball of healing, loving light traveling across your collarbone and down your left arm, from your shoulder to your elbow, your wrist and hand and fingers, and then all the way back up to the torso. And picture that little ball of loving light, like a slow moving pinball going through all of your organs in your torso, completely relaxing it, bringing peace and calm to each organ. Your stomach, your liver, kidneys, just peace and calm. Allow it to travel over the right hip, all the way down your right leg, to your toes and the sole of your foot. Back up and over to the left leg, circling all the way down, bringing that love and light to the toes, and then back up, leaving both legs calm and relaxed. Bring that ball to your heart center. Allow it to fill your heart and allow some healing of any emotional troubles or some of those ethical issues or any problems that you may be carrying heavy in your heart. Just allow that light to fill. If you have a particular place in your own body physically, allow that light to travel there, picking up that extra tension and leaving behind love and bliss. Watch that stress dissolve away as that light moves back up to the top of your head and exit the crown, leaving your entire body filled with relaxation. Taking a moment just to notice how you feel. Notice your breath moving in and out of your body. Notice any sounds that may be around you and the surface, maybe your chair underneath you. Picture, if you can, where you are in the room and the space that you're in. When you're ready, wiggle your fingers and your toes. Take a nice deep breath. When you're ready, open your eyes. Just do a check-in and see how you feel compared to when we started. Maybe just a few minutes ago, or maybe when we sat down an hour ago. I know I came in hot with my lunch and trying to get here on time, and even just talking y'all through is a little calming. Yeah. Anybody feel any differences where it feels a little more calm?
Yeah, that was amazing. My whole body feels like just relaxed.
Maybe a little tingly. Yeah.
Yeah.
And that was just a couple minutes. That really was probably what, maybe 3 or 4 minutes. And you can do it by yourself, but it really is nice if you have the time just to talk someone else through it. It's nice to have someone else just guide you through that. But starting, so you have 2 little things, starting with that superhero pose and then finishing off with that. I call it a little ball of light. You could call it a blessing ball of light, whatever you want, just to kind of go through and pick up that stuff. Any questions, y'all? It's been kind of a heavy day. All right. Blessings to everyone.
Thank you, Stacy.
Yeah.
Amazing as always.
Thank you.
Awesome. All right, y'all take care. And we'll see everybody soon.
Yeah. And just as a reminder to fill out your surveys after, Maggie will be sending emails, and our next session will be May 18th. And the topic is going to be, I don't even know. Oh, GI symptoms. And we're going to have Dr. Kenzie Daniels joining us from UNC. So it should be a great session, and we hope to see y'all then. Bye, everyone.
Thank you, guys.
Thank y'all.
Have a good day.